Oh. All right. Scott, let us know.
Okay.
All right, everybody. We are now streaming live, I believe. Let me see. I'm going to look on our Facebook page right now. It should just having technical difficulty. So let me see if, oh, there we are. Yes, indeed. We are on and we are live.
Okay, good. We made it.
Figured that one out.
Hi,
everybody. Thank you. Sorry for the technical difficulties. But welcome to VBF Facebook Live. I'm on tonight with, and let me know, please, if you can see us. It says there's 8 people on already. I'm on tonight for the first time with Dr. Gerald Goldberg. He's a board certified derm and pediatrician and laser expert. He's been doing lasers. We call him one of the laser kings because he's been around with Rox Anderson, Dr. Rox Anderson, Dr. Stuart Nelson, and Dr. Roy Geronimus. So they've been around, and there's others that have been around, but they're the ones that have been involved with VBF. He's also clinical professor of derm and pediatrics at the University of Arizona and founder of Pima Derm, which is Tucson's leading derm group. So I can see you all on, and oops, sorry, got to turn the volume down here. Hold on so I can see the questions. Oh, hi, Donna. Hi, Scott. Thank you, everybody. So Dr. Goldberg is here to answer your questions. Any questions? Hi, Lindsay. Great to see you on to answer any of your questions concerning laser treatment of any V-bars. Hi, Tara from Florida. Let us know where you're from. Ask any questions that you have for Dr. Goldberg. You'll hear him answer them live. We will say your names, whether it's Laura, Lindsay, Laura, Tara, Pamela, Scott. Hi, Lindsay. Any of you that have any laser questions, and in between that, Dr. Goldberg and I were talking about any new studies, and there's this imatinib study that will be coming out. Is that correct, Dr. Goldberg?
we're working on it. It's in the early stages, and we're just getting all our ducks in a row to get things set up. One of the first human studies of this new formulation of a FDA-approved medication that's been around for many years that has a lot of promise as an angiogenesis inhibitor. So we're still looking for that magic bullet.
So then the premise of this would be laser and then use the drug, and then it would keep it from coming back?
Yeah, that's the idea. So
that's the hope.
That's about a decade ago, Stu Nelson did some really paradigm altering work in an animal model using sirolimus or rapamycin as an adjunctive treatment along with laser to optimize results and duration of effect. The observation is, and many of you may have experienced this, is that we do everything we can to optimize our laser parameters to get us the very best result possible. So we do that, and then the body has other ideas. They want to repair. They want to repair what the laser is targeting, what it, quote, injures our blood vessels, and the body responds by trying desperately to recreate some of those vessels to have what we call neo-angiogenesis, or new vessel formation, as a response to the injury, meaning the targeted destruction of these blood vessels, which we're working on. So we're looking for that magic bullet after optimizing laser plus a medical treatment of some kind to prevent that recurrence of the blood vessel, to increase the duration of benefit, and to also prevent the enlargement or thickening that occurs in the 3rd, 4th, 5th, 6th decade of life. And some of these port wine stains have become nodular hypertrophic. Some 50 or 60% by age 50 will become thickened, nodular, and those kind of birthmarks that I kind of specialize in as well. But the point is, if we can find a an adjunct that is better than the sirolimus. Unfortunately, the sirolimus or rapamycin has not worked wonders in humans after laser treatment. So we're looking for the next newer best thing, if you will. And imatinib, a fellow named Jack Arbisser out of Atlanta, has done some wonderful animal study models.
Well, it's
which
always,
look very promising in terms of decreasing the angiogenic response.
that's phenomenal. Now we've got a bunch of people asking you questions. The first one comes from Jody Lee. Hi, Dr. Goldberg. Would love any thoughts on laser for the lip. Does it work? Does it alter pigment? Is there ever a point where it's too late to try the laser, like when it starts thickening?
Thanks for your question. The question is, it really depends on who, when, and what we are treating. So at what age are we talking? Are we talking about an infant, a child, an adult?
She's 8 years old. She's 8 years old, and she's between a type 2.5 and 3 skin type Fitzpatrick. And she has a small blush of port wine stain on her lip with a less than 10% growth that you're seeing at age 8. And she is migrating into that pre-puberty stage.
Okay. So at this point in time, the lesion itself is flat and the lip is pretty normal. It's not.
It's a little tiny bit, like 8%. Like if you really look at it, you can see a little fullness.
Okay, it's just in one part of one side.
Right,
of the lip.
one
Okay.
side.
Well, the answer is yes, it can be effectively treated. Lips tend to be one of the more resistant areas, however. So we need to be persistent and have continued incremental treatments. And often you don't see all that much benefit from an individual treatment or 2 or even 3. And you can treat onto the vermilion, the colored part of the lip as well, safely, carefully, with either, typically the pulse dye 595 is the standard, the gold standard to be used. You can also use a 532 KTP, which is a green light laser instead of the yellow light. Also pulse it, and the difference in most of these are they're contact cooled, but there's a newer device, the Derma V, which is also spray cooled, like the dynamically spray cooled pulse dye that we've used for many, many years. So we're making some advances, and I think if you find that it's plateauing, that it's just not moving after a treatment or 2 or 3, there are different kind of techniques we can use to improve that stubborn, quote, resistant or plateaued response. What I often do will be to layer at the same time multiple passes of the same modality. So that, let's say the 595, you're using that same wavelength, but you're using a longer pulse width to catch some of the deeper vessels, and then a shorter pulse width. So you're layering different parameter treatments in the same session, okay, to try to get the very heterogeneous vessels that are present in these lesions. So some of the vessels are very superficial and very tiny in caliber. Some are deeper and some are bigger in caliber. So because of that, different wavelengths and pulse durations can often be effective. The other thing we could do is use a different modality. So if you use the 595, you can carefully use a 532, carefully use a 755 Alexandrite laser, or an IPL has been used, intense pulse light. These have all been used in appropriate hands with experienced people, because you can also, if you try to get too aggressive, you can also have issues with problems around the lip. I'm reviewing a paper right here from Lasers and Surgery Medicine on perioral scarring as a complication of laser treatment for I'm reviewing that paper as we speak tonight. So it's about creating scar if you're not careful. This one used the 1064 laser, which, as we all know, is a very treacherous, very difficult to control the depth of that laser in many cases, particularly when you're using it for a flat superficial lesion, which is really a no-no for the most part. We only use it primarily in thickened thickened port wine stains. So I hope
So,
that answered your question, or if I didn't, chime in with additional question.
yeah, we have a lot of questions coming in, but I just want to add, for someone like Meghna who's 8, would you do that under anesthesia?
Well, first of all, does she want it treated?
Well, her mom wants to not keep it from thickening and get it back to it's marginal right now. It's only an 8 to 10%. So to me, it's ideal but if her laser doctor is a good doctor, but he's not comfortable with treating the lip, and you are. That's the difference. The doctor has to be comfortable, understand pigment, because she is pigmented, which means her vermilion, because of her type 2.5 brown, is pigmented darker than a normal vermilion. So you, in my opinion, you have to really understand pigment, the vermilion tissue itself, and then the laser, and not everybody has the experience that you have,
So
but
a couple things you're mentioning. So skin type, and then also anesthesia you mentioned. Okay. So skin type, when you have a darker skin type, and frankly, 2.53 is not an issue. If you're doing type 4 skin, you're going to have more tissue reaction, meaning you have the melanin, the pigment in your skin competes with the hemoglobin in the red blood vessel for the laser light. So you get more epidermal non-selective injury, if you will, to non-targeted pigment in the skin. So you want to increase cooling usually in your device, and you want to decrease the fluence, and you want to increase the pulse width. So you want to do all those maneuvers to soften the blow, if you will, to the pigment, because pigment will respond with really short pulses, high intensity fluences, particularly at darker skin types. So altering your approach in darker skin types is essential, and understanding that the differences of laser tissue interaction in darker skin types is important. And then in terms of anesthesia, on an 8-year-old, I find I have the most success with an 8-year-old who is with the program, meaning it's not us as parents and doctors saying, let's do this. We need the team approach.
she's very with the program.
She
She's
very
very with
much
it.
is in a school age where she may be
Yeah.
sensitive to peer pressure, et cetera, saying, I do want to have this treated, mom or dad, and let's get on this. And so that makes it much more easy to work with the child slowly, carefully, cautiously. And a number of tricks. Number one, topical anesthetic is number one. Number two is distract anesthesia, or talk anesthesia, I call it, where you really have some form of distraction, whether it's an iPad with a cartoon type thing that'll get their attention while they're doing a pulse or two, or just talking them slowly through it, or just saying, look, we're going to do 2 pulses. It's going to feel like a snap, and I snap their skin typically. Let's do 2, and then we'll take a break. We'll put some ice on it. And when you're ready for another pulse, let's give it another pulse. So, in a small area, we can just take it pulse by pulse. I'm going to do everything I can to avoid it's for a small lesion. General anesthesia really in an 8-year-old is really not appropriate in my
The gift in
we've not
you.
even so we talked about topic, we talked about distract anesthesia. Number 3, the commonest, the most easy thing to do is, like at our dentist, we put topical numbing inside the vermilion, and to numb up the inside of the lip in the sulcus by the gum, and we put topical, and then we sneak a small little injection that you barely feel to numb up the lip. Anybody who's done dental work knows a quick little block is extremely effective, and the kids don't feel a darn thing. Okay.
Well, I think
number 3 is Pronox, which is a nitrous oxide laughing gas. And if you have a kid who's done snorkeling, or you can have them practice with a straw, working with their breathing through the mouth to at least get them into a lovely little state where they don't care about what's going on as much. And you sneak a couple pulses in. If they start feeling something, you give them some more gas, and it's quick in and quick out. So you get to a nice state where you're tingly, and then you're goofy and loopy, and you don't care what's going on, and they rock and roll. You can rock and roll with a few pulses. So all those techniques I would do before I'd even consider going anywhere near general anesthesia, because expense and risk of the general anesthesia itself, and the repeated anesthesia we know has issues with neuroemotional development, etc. So those are tricks that I, as a pediatrician, I'm very comfortable working with kids and taking your time and no rush, and we'll just do a pulse or two at a time. Let's do 3 pulses, and then you find some kind of reward system. After 3 pulses, if you get through 3 cycles, we get the thing done, we'll get you a treat, whatever it happens to be. You find some kind of reward.
Thank you. We have quite a few people with questions. Pam Sullivan wants to know, is imatinib used locally or systemically?
Good question. And there is no study on either for this indication for vascular malformations at this time. There are studies there's one out of Iran of all places, and there's one out of Japan using topical agent in a vascular application. I'm not aware of any systemic use of Gleevec in this indication. I am aware of one of the other prominent newer angiogenesis inhibitors, which is alpelisib, which you actually mentioned previously, Linda. That's been used systemically, orally, in very difficult vascular venous malformations, and we're getting good responses with it. So there is response from that agent, which we're not testing at this point because it's not easy to formulate in a topical like Gleevec or imatinib is. So that's why we're focused on that agent first. If this doesn't pan out, I'm sure we'll be working toward other ones. So it's expense also. The alpelisib is very, very expensive and can't really be formulated topically very easily. I guess we could consider doing it in a systemic manner, but then what we're trying to do is demonstrate a differential effect, taking a lesion, let's say a full cheek, or ideally if it's 2 cheeks, treating one section with a control just with a pulse dye alone, and the other section with pulse dye plus imatinib. So we're trying to do a split lesion study, and doing it systemically, we wouldn't be able to really ascertain what's doing what.
Thank you for that answer. Eliza wants to know, is there any way to foretell which port wine stains will thicken and cobble? I'm 40 years old and mine has not.
Fantastic question. It's one that has been troubling me for a long time after seeing kids sometimes 15, 18, 20 years old with incredibly deforming birthmarks. Why? What is triggering that response, that soft tissue enlargement? And I asked that very question to Ann Comey, who's really a genetics, she's a neurologist, but is a genetics expert who discovered the GNAQ mutation in Sturge-Weber syndrome. And we all know that the Sturge-Weber syndrome involves a triad of vessels, venous problem in the brain, eye, creating glaucoma, and facial port wine stain, that triad. And we know that a good number of those people will go on to thicken and enlarge. So that may be one factor, is that GNAQ. But I very much want to take small biopsies, and there is a panel available out of WashU and Seattle, where you can do a panel of what's called vascular growth markers, or one's called a somatic growth panel and the other's a vascular panel, meaning these are molecular signals, triggers, that may give us a clue as to which of these, if we get a little piece of skin at age 20 of a non-thickened birthmark, can we get a group of 15, 20, 30 patients and follow them longitudinally? This is a long-term study. We can't do this tomorrow and have answers. I guess what we can do is take one that's already enlarged, and I thought of this as well, already enlarged in some areas. In other areas, it's flat. So take a differential biopsy from the thickened areas and look at their cell markers, and take one from the non-expanded areas and see if there's a difference in expression, and that may help answer that question as well. So I've thought of it in many different ways. So I don't know in your case how to predict it at this point in time, but if you'd be willing to give a sample of your skin, maybe we would get a marker panel from one of these two institutions that is offering it, to at least see if we then, as we're uncovering these clues, if you might fit in one of those patterns of yes, it will expand, no, it won't, or somewhere in between, intermediate, we don't know, or indeterminate, we don't know. But great question, one that I'm struggling with, and hopefully we'll start to find some answers, because it'd be wonderful to know if those folks that will be more apt to have a thickened response, to be much more aggressive with them, to start using some of these angiogenesis inhibitors before, during, and after treatments, between treatments, certainly as an adjunct after treatment. Because we're looking from Dr. Nelson's studies 10 years ago, we know that within 10 days, 12 days after the laser, quite a few of those vessels have already recanalized, reformulated, found new ways of regenerating. So we really need to get after it right after treatment, ideally even before treatment. Maybe that'll inhibit that angiogenesis from the get-go. That's a
Thank you.
response to the laser.
Thank you for that. And for people who have questions for you, can we share with them your contact information
Sure.
in the discussion? So our staff is on. Barb Humphreys is on from Canada,
Hi,
our friend
Barb.
from Alberta. And I mention her because there's a good question from the next parent. Her name is Lucy Burke, and she said, how difficult is it to get an eye shield for a baby? My derm claims she cannot find one that will work. And I know Barb has a company that she knows that has these eye shields. So Lacey, Barb's in our string here, Barb Humphreys. She's the leading nurse laser expert probably in the world, and she's out of Alberta, Canada. And I think you two can connect, but I don't know if you know the answer, but in our
Yes,
laser
as a pediatrician, I've been using eye shields in infants and newborns and babies and children for years, and it's really, I don't like to demean anybody, but it's a little lame, to be honest. I mean, you go to any basic eye shield, the optical companies that are laser optical companies, they have all kinds of arrays of eye shields. So either the individual is not comfortable putting in eye shields in babies and infants and children, but there really is no problem. Matter of fact, they're a lot easier to put in infants and children than, say, an 18-month-old, a 24-month-old who's alive and well and doing this kind of thing, trying to get an eye shield in. That's much more challenging. So baby you can control for the most part, and you need a small eye shield for a small baby. You can't put a big fat shield in a little infant. So you need specialized small infant eye shields, which are readily available at any supply company that is a robust laser optic company.
And you were on the laser guidelines team that we just put those guidelines together, and using a shield is a must when lasering around the orbit. Otherwise, all these babies grow up and look like they got a bullseye around their eye because everything else gets lasered but the eye. So
we typically go right up to the eyelid. The issue is we have to be a little careful with the eyebrow hair, and so there is tendency to work on that upper eyelid up to the brow and then just over the brow. So you tend to get a little red streak where we don't treat, because in babies and infants, the hair bulb, the area that is the stem cells for the hairs, can be relatively superficial, and you can injure them with the laser, even though it's not designed for hair removal. So we tend to be a little cautious about using it on eyebrow hair. So, but eyelids are fair game with an appropriate eye shield, always.
Thank you. Bobby has a great question. Bobby Pugh. Our 12-month-old has had 8 treatments with the Candela laser for port wine stain on her face, but we haven't seen any improvement. We are taking a break until she's 3, but do you have any advice? Doctor has tried a lot of settings. She's saying they really haven't seen much improvement.
Very difficult. Where is the port wine stain located?
On her face.
Well,
And the baby's 12-month-old. It's a female.
Yeah, where on the face? I mean, we
just
tend to see
said
jawline tends to be more resistant, lip tends to be more resistant. Center cheek, temple, forehead, no nasal, tend to respond pretty well. So if it's in this region, cheek, we call V1, V2, which is there are three basic patterns or of distribution on the cheek. On the one, the forehead, temple tends to respond very, very well. The second, next, also pretty well. This tends to be the jawline area tends to be more resistant, and the lip tends to be more resistant. So if those are the areas, those are tough, and frankly, you can, as I said, try to layer it. It sounds like they have done this where they've layered at the same session, layered different pulse widths. In other words, typically we'll look to the skin to make sure we get, in most cases, a purpuric endpoint, a darkened bruise-like endpoint in our treatment. What I'll often do is do a multi-pass technique where I'll do one pass where it's longer pulse width and may or may not decrease the fluence a little bit to get some of the deeper, broader vessels. Then I'll go over a second pass with a purpuric endpoint with a significant a fluence and a pulse width that's lowered pulse width typically, and a fluence that's appropriate to get a good purpuric response in the same treatment session. The other thing that can be done is intense pulse light has been shown in some cases with excellent practitioners to move port Weinsteins that have plateaued. And the other is carefully using the KTP 532, which also can be used and layered as well. I would not, in a flat port Weinstein, run to the 755 or 1064. I think that's trouble waiting to happen. But I think layering and using multiple different safe wavelengths, the green light 532, yellow light 595, and IPL, the broad band intense pulse light, are ways to work. And sometimes you do need to take a break. Age 3 is a difficult age to resume treatment, honestly. It's much easier to do it when the child is more with the program, meaning they are really motivated to have treatment where they can handle Pronox, let's say, or a couple little injections, that you're going to find more success at, say, age 5, 7 or so, when they can express being on the same team to have this done.
Okay, thank you for that. And those of you who are on, we have quite a few people on. This will be on our website tonight on Facebook, and it'll be shared to the groups tomorrow. It'll also be on our Facebook page, so you can go back and re-listen as many times as you want to what Dr. Goldberg is saying, because he's giving us a lot of good information. So Erin has a question, Erin Annell. My daughter just turned 6. Her port Weinstein has been resistant to treatment, and I'm mostly concerned with her ear, as we have not done many there. What kinds of changes can we expect, or options do we have?
Okay, so age 6, and are we getting good response elsewhere?
No, she's saying it's resistant.
And it's worse around the ear. There's just been fewer treatments on the ear. Is that
right? And she's concerned. So
typically, the ear can be treated pretty effectively. It's somewhat intermediate in terms of its responsiveness typically. But the same thing I just said on the other patient who's plateaued, I think you just need to be creative in terms of some of the other ways of using it, multi-pass techniques, multiple different wavelengths, multiple different pulse widths and fluences, some non-purpuric passes, purpuric passes, often in the same session. And other than that, I mean, some are resistant, and there's no magic bullet. I'm hopeful that we will be able to find something that'll be a good adjunctive treatment to make that optimal laser settings that we've used be able to constrict those vessels and keep them closed, instead of having that neoangiogenesis response and recurrence of the port Weinstein following laser. So I don't have any real additional magic bullets at this time, but I'm hopeful that it's possible that we'll be able to use other modalities, like even a non-ablative modality. On top of this, we use this for our complex malformations, and then in putting on the surface various adjunctive medications to turn off blood vessel. Maybe that'll help the penetration of some of these. And there are a lot of other things, in kind of in the hopper that we
A
can,
lot of tricks.
tricks that we can utilize, that we utilize in our adults, that we can now migrate and use in our kids. For those of us who are comfortable doing different modalities in kids, which I use fractional ablative techniques, non-ablative techniques, and those can be adjunctively used in these difficult, resistant, and recurrent port Weinsteins.
And I'm sure you'd be willing to look at pictures and have them share with you what laser and what the settings are, because it could be settings. There's so many different things. Like Dr. Geronimus says, sometimes it's a touch and a feel thing, and sometimes it's that. We have a pretty long question, but it's from one of our, Jody Cower Mater. She's been around a long time with VBF, and she's an adult. She's 55 years old, and she's had 90 pulse dye laser treatments and 3 IPL treatments. She's had pretty nice results over the year, but then she gets to a point where it's not doing much more. She wants to know if you'd be willing to see her or give her a consultation or something. She said, do you have recommendations? I like my doctor, but he doesn't really have much experience. He just uses the same settings, and I spend my winter in Casa Grande and would be happy to travel to
Oh my
Tucson.
God, sure. Come on down. That's the first thing I'd say.
Yeah,
I'm
there you
happy to
go.
do like a Zoom session or take a look at you, and I'd be happy to review what's been done. 90 treatments. Wow. I mean, I maybe have maxed out at 25 or 30 in a few of my long-term patients. Is it thickened? Is it a thickened port Weinstein as well? Do we know?
No, it's not. There's no overgrowth on her. It gets dark and then light and dark and then light, and on some uneven texture from the last time I've seen her. But she doesn't have like massive tissue overgrowth or anything like that. I think she just has a rapid refiller. Like, that's what I call them, some rapid refillers. But she's been on top of it, and who knows, she could be, by being on top of it all these years, keeping
Right.
it from thickening. I mean, we
Right.
don't
Well,
know.
I think, for instance, if I got my hands on her,
You
I
will. She's
I
coming to
would,
see you.
I would consider, just as a if you're willing to do a quote experimental treatment, we would consider doing topical imatinib on as an adjunctive measure. First of all, doing everything we can to optimize with a double pass technique, using a non-purpuric and then a purpuric pass. We would do the Gleevec on part of it and not on the other part, to see if we can get a differential effect. We could also do non-ablative on some area and put the Gleevec on top to get better penetration. So there are maneuvers to see what we can do to move this plateaued response ahead. No guarantees. It may not be of any much more effectiveness than what you've experienced, but it's worth a try. If you've had 90 treatments, holy moly, I would give me a couple shots at it with different types of adjunctive measures, and I cautiously optimistic we can move you along a little bit anyway.
Thank you for that. We have quite a few more questions. So Caitlin Smith says, my daughter has had 18 laser treatments. We recently moved, and the only laser near us is in a plastic surgeon's office. Our daughter is 11 months old. Should we worry about her going to a plastic surgeon?
I can't comment about that. What you need to know is what kind of experience the doctor has had. There are very fine plastic surgeons who do this and do it well, and there are others who do not really. They do surgery. That's what they're expert in, and don't necessarily aren't up to the highest standard for, let's say, infants and children. I don't know, unless this is a pediatric plastic surgeon specifically, then they may have specialized expertise, and that would be fine. I think you need to inquire what has their experience been with infants and children. 11 months old is still a very good time to really be moderately aggressive in terms of getting it done while you still have control of the baby, meaning you can do your treatments with minimal anesthetic intervention, whereas you come in to start treatment at 18 months, 2 years, that's much more difficult. So at 11 months, even up to 15 months, we can pretty much manage these kids pretty well with local minimal sedation, even a little Benadryl, something really gentle, just to calm the child down a little bit, and topical anesthetic, and if you can sneak a block in, that works pretty well as well. But that would be the focus, is to be moderately aggressive in those first months of life.
Thank you. The next question by Nur Nashua. You answered it before, but I'd just like you to repeat again. What percentage is standardly accepted of the port wine stains that will thicken? Is it 60 or 70% around there that will thicken?
The data that I've seen, actually, Roy Geronimus talked about this at our session at NYU a few weeks ago, and the data I have. Can I minimize this? Is this going to mess things up here? The data I have, I don't know if you can't see my screen, but age, here it is, age 66 to 75 is 66%.
Okay, so that
hovers
means
around 60% at age 50, and somewhere around 35% up to age 45.
so there's still a percent that don't get them. So the ones that are asking questions, oh, mine's flat and I'm not thickened, somebody's got to make up that 30% that never thicken, right? Yeah, so that could be it. We don't know why some don't. So that was for you, Nur. And Erin Meredith says she's just making a statement. I'd like her to follow up, but she said her son is on alpelisib and doing well. So
for what is he being?
I don't know.
So is it an extremity, deep vascular malformation?
So Erin, if you can follow up that with where is it located? Is it a port wine? And how old is he? Correct?
Yeah, it'd be very. And where are you located? Who's
doing it, and where are you located? And while we're waiting for her, because we have a lot of other questions, Marina Sanchez said hers is changing and it's becoming painful, her port wine stain. What can be done for the pain?
What age are we, and where is it? Is it on the face?
She just says her, and again, for all of you writing questions, you have to remember we're not bringing images up. We can't do that. So you have to be more descriptive in saying your age, where is the birthmark located, and where is the pain located, or if it's a child, how old, where is the birthmark located? So we'll have her.
That's very. I can't comment without knowing more about.
I know
It's unusual for a port wine stain or a facial stain, port wine birthmark to be painful. I mean, that's not. With treatment, it can be painful if you have an erosion, an ulceration, or something. That can be painful. You have an infection, that could be a little painful, but in and of itself, it rarely is painful. Now, if you have extremities that have deep venous malformations, those can be painful or associated with swelling and other issues. So we need to know more about where you're
located. Yeah, you need to know more. Nancy Rogers is watching and says hello. Barb Humphreys mentioned Innovative Optics is the name of the company for the eye shield. So thank you, Barb, for that information.
Yeah, that's a company that I use. I just did. There's Laser Optic, I know, is another one. Is that what you said? A Laser OPTEK is a company.
So a lot of people are talking back and forth. Is there a way to correct marbling in an infant from the laser? Now, are you saying, Lindsay, that the laser caused the marbling? Or she said, is there a way to correct marbling in an infant from laser?
Is it this hemangioma or is this a port wine stain?
Port wine stain, I'm
Okay.
assuming.
Typically, that's just from not well overlapped spots. So, because the laser itself, each spot delivers a pulse in what's called a Gaussian curve. What that means is if you look at, like a standard bell curve, so it's hotter in the center, not as hot in the edges. So if you don't overlap your pulses a bit, you're going to get that marbling, that kind of lacy checkerboarding that we all try to avoid. So yes, and it happens to all of us. We're not perfect. We create some of these areas that aren't as well treated. We overlap too much in some areas, which can be an issue too. But we want to overlap 20% or so, 30% to get good confluent application of the laser and more even kind of distribution of the laser energy. And yes, once it's marbled, you just go after those interstices, those little web-like areas, and that's pretty straightforward to treat. We see that pretty much when we treat other things like red necks, poikiloderma, or blush-like rosacea. We'll see that lacy kind of pattern, and I always tell patients it's going to take a couple treatments anyway to remedy the laciness that comes on after treatment as well.
Well, I just learned something new, and I'm really glad that there's that 20% overlap, because those purpura dots, if they're like this area is not treated, and even if it's marginal, but you're saying you need 20% with the scatter, and then you're going to get a confluent removal. Then you're going to get it. So that's very important.
You can see it when you're treating, and if you have a little infant or a child, moving around and whatnot. I mean, you want to just get your pulses in and not create a lot of havoc in the treatment room, so often you will get incomplete treatment with one session, and so you will have skip areas and areas that you need to come back and go after them.
So Sherry is a grandmother of 11-month-old granddaughter who has quite an extensive port wine. It's on her back thigh and down to her foot. And she's saying the lower leg is not responding well, which you did mention. The more distal away, the harder. But the rest of it is responding well. Is there a different approach or a different laser that you can use for that resistant foot area?
Good question. How old's the patient?
11 months.
Yeah. And Roy has a significant experience. Roy Geronimus has a significant experience treating these kids very early with the newer Prima device, which has a larger spot size, higher fluences, and you're able to do large areas more quickly. So you're not doing a long 45-minute, hour kind of treatment for these extensive, massive port wine stains. Having said that, we know that legs particularly, and arms for that matter, hands, can be more difficult and resistant to treatment. So if you catch them early in the first year of life, and you can be fairly aggressive and treat these areas, they can respond. But in my experience, if someone comes in at age 3 or age 5 with a massive, extensive confluent port wine birthmark on legs and arms, I often dissuade them from treating. Now, some of those, there are syndromes that you can have, particularly if it's in one-sided. You get hemihypertrophy or thickening enlargement of one leg, or Klippel-Trenaunay syndrome, they call it. And we like to think that our treatment early on will help minimize that thickening and swelling and enlargement, but I'm not sure that that's proven, because it's a more complex malformation than just on the surface in many cases. So I don't know if I'm answering your question, but I think if you're really motivated to have it treated, I think treating it aggressively in the first months of life is the way to go, with someone who has ideally the larger spot Prima available, which is not terribly available at the moment. I don't even have one in my clinic, but I know Roy is very involved, and Stuart on the West Coast, and I think Paul has one in Houston, and there are a number scattered through the country. And we know this next year we're going to be getting a newer Prima coming out, Prima Plus. I don't know I can't remember the name but I've been talking with the developers at the Candela Corporation, so stay tuned. We have a higher fluence, more ergonomic device coming out with large spot size. Higher fluence is available, so stay tuned for a newer, better device coming out. We're always seeing new technologies coming, and so we're pretty excited about that.
And I've just written to Candela to see if once you guys have tested it, the experts that they have tested, if we can do another free laser day at Candela headquarters with it, so we can get some
That'd be
patients to
fantastic.
come in and have that experience. This is another great question from Samantha Childs. She says, does purpura mean the laser's working? My son has had 19 treatments and it's lightning and it's still getting good purpuric response. We're going every month. Would you just keep at it until there is no purpura?
Well, that's a little bit controversial because I heard my esteemed colleague, Dr. Geronimus, who now is treating his infants, particularly almost on a weekly basis, which is kind of unheard of among those of us who've been doing this for many years. But he's trying to push the envelope. So by doing it weekly, he's interfering with that angiogenic response, and he's actually looking at a different treatment endpoint. He is not moving the skin to a purpuric endpoint. So I don't know if this is answering your question, because it's still not 100% known, because I've always grown up, and Rox Anderson and others have all, and Stu Nelson all have taught me over the years that the purpuric endpoint is the treatment endpoint that is the desired optimal endpoint in most treatment. If you don't get that purpuric response, sometimes it is sub-therapeutic. We're not getting the response you need, but sometimes we certainly see other vascular lesions that we treat, blood vessels, for instance, discrete branch-like vessels on the face, where we don't reach that purpuric endpoint, but we gradually heat that vessel target slowly, incrementally, so it's closed down without purpura. So yes, it can be effective to treat without purpura, but you have to have the right combination of vessels that are responsive, and it can be. That's why often we'll treat a subpurpuric and then a purpuric in the same setting, in the same session, with different settings, to see if we can't optimize both that non-purpuric response and purpuric response in the same session to get different caliber vessels responding. So yes, subpurpuric can be effective, because we treat some things in a subpurpuric manner very effectively, like blush-like redness or red necks. We treat to a subpurpuric threshold with the pulse dye laser. So we know that it can be effective. It's just not shown to be as effective in most cases in port wine birthmarks. So so that's still a question that we all are asking, particularly in light of Dr. Geronimus's recent studies. So stay tuned a bit, and I would encourage the doctors you're working with to work with you to do multi-pass. If you've plateaued, particularly, do multi-pass technique with different endpoints, and so that help to answer the question, but also to move it forward a little bit more if we can.
Right, thank you for that. And just for all of you, because there's so many still on with questions, we weren't able to get it started until 8 minutes after, so we will stay to make up those 8 minutes, so you get the full 60 minutes that we do every month.
Good. Ask
And
away.
also, this is very valuable. Wonderful question, and this has come up. Mary wants to know, at 71, should someone be done with laser, pulse dye laser done in the past with minimal improvement?
I'm very sensitive to that question. Being around that same vintage, I won't be more specific than that. I would simply say, first of all, is the port wine stain flat and relatively straightforward, or is it thickened and needs additional attention to other types of modalities, meaning different wavelengths, different modalities to help shrink or decrease the size of some of the thickened areas? So if it's thickened, yes, you can move it at age 71. And for some of my peers at that young, tender age, we hope to be around for another 5, 10, 15, 20, 30 years. Who knows? So yeah, you want to feel good about who you are, how you look, and it can be very worthwhile to go ahead and treat. I've treated people in their 60s and 70s and getting very good responses and very gratifying results and satisfying results for our patients. So age itself is not a determining factor to stop treatment. So I would not say that it can't be further responsive. I think it has to do with what's been done, how it's responded, how it looks now, is it changing, evolving to thickening, and you need a different treatment approach if that's the case.
Thank you for that. Cuban is writing to us from Aberdeen in the UK. I'm going to condense her post because it's pretty long. Her daughter's 13 and 5 years ago, they used a pulse dye laser and she didn't see much improvement. So she wants to know, because they found another doctor that uses the pulse dye, you know, what are her options? Will it be effective? And I think this is a good time to talk about that no two doctors use it the same, and she really should go because the 5 years the lasers have changed, but the expertise of doctors has also changed. So she just
Very
wants to
true.
know, because she didn't get much success with one doctor 5 years ago, is it worth it, since it's the same laser 5 years later, which is now, to try a treatment?
Yeah, we know that there have been advances. There are at least two, actually three very important laser advances that, in terms of device alone, and those of us who've been using these for quite a long time are using our devices in more creative kinds of ways, as I've mentioned before. So it definitely be worth trying. I have a good contact in England. Can I mention a name? Dr.
Yes, yes,
Firas Niami is a wonderful, very thoughtful doctor, very skilled. Firas Niami in London. And I don't know if Dr. Nick Lowe is still working, but he did pulse dye. I saw my first pulse dye with Dr. Lowe in Los Angeles in 1988. Before we bought our first laser, I went over there and saw him in his operatory in Santa Monica. And I know he now practices in London as well, or he may be retired now. I don't know. I haven't seen Nick in a while. So those are two names, Nick Lowe, but Firas is up and running and is a wonderful person and physician, very interested in vascular malformations.
Would you be able to send that contact info, because people will be asking us how to spell the name and how to find
Yes,
that
yeah.
doctor?
Yeah, Firas, yeah, Firas, and Niami is hyphenated, Ni dash AMI, Niami, but I can send that through.
Okay, thank
I
you
have
for
his
that, because there's a couple people on from the UK. Hi Shannon, she's saying she's on from Saskatchewan, and Shaheen is a 47-year-old woman and noticed my right arm with the port wine is getting larger. It also feels heavier. And is there anything I can do to help reduce the pain?
So it is larger than the other arm. Is that true? So it really is a variant of the clipotrodontic. So often there are deeper vascular elements, whether it's dilated veins, venules associated with this, and that can stretch nerve endings and create soft tissue enlargement. And it's interesting that alpelisib has been shown to be helpful in those cases. So that's something to explore. I don't know if that's how available. Barb may know that's available in Canada, or if it's experimental or what, but that's been shown in some of these deeper, I've seen some papers on alpelisib for deeper vascular malformations in the setting of KTW and that kind of thing. So that's something to look into. But the pulse dye alone is not going to affect the pain, in my estimation, because it doesn't penetrate deeply enough for some of the deeper elements of the complex vascular malformations.
Thank you for that. And I love this next question because it just shows how VBF has really changed the paradigm with getting that word out that newborn babies need to be at least connected or looking into getting treatment. So Kelsey writes that her niece is only a few days old and she has a port wine to the right upper eyelid up to her forehead. And she said that this is new for the family. They're all trying to educate themselves and who should perform the laser, being that it includes the eyelid. Do you wait until after seeing an ophthalmologist or do you start the laser ASAP?
That is a critical area. Is it over by the nasal root, or is it?
She says over the eyelid and up to the forehead.
Right. That is an area that we do have some concern about association with the Sturge-Weber syndrome. So that'd be the first thing. You mentioned ophthalmology, so that is something where early on you do want to get someone who's experienced in terms of working with both a experienced pediatric dermatologist, typically someone who's comfortable using laser in infants and getting on it early and getting an eye pressure check early on. You do that because there is a risk of developing glaucoma with that location of the port wine birthmark. Having said that, we know that this area is quite responsive to laser therapy. So typically 3 to 5 laser sessions in the first year of life will often significantly lighten it. But more importantly, we have to keep an eye on the eye, literally, and get serial measurements over the first year of life, particularly on the eye pressure changes that can occur if there is an association with that. And, if there's no other neurologic developmental kinds of issues and the eye pressure is normal, then there's a good chance that it's not associated with Sturge-Weber and it's just an isolated skin-only defect. But that's something to be aware of and get someone who is knowledgeable about Sturge-Weber and its associated issues with a port wine in that area, and to get on it and treat that area. Eye shield treatment is pretty straightforward, frankly, as long as you have someone who's comfortable treating infants.
And I'd just like to add to that, on our website at birthmark.org, you can go to the Find the Doctor link and look up doctors in your state. Everyone that's on our website is someone that we know and trust. You can also email me at vbfpresident@gmail.com. Tell me where you live and I will let you know where and who can be seen that's a good Sturge-Weber expert, a good ophthalmologist, and also a good laser expert, because you want that team and you want to make sure that they're all on the same page. That's why we have our annual clinics and conferences and bring all these experts together so that you get the best of the best. Jody wants to know, will you be getting the new Prima laser, the new one that'll be coming out? I thought that was a cute question.
Will I be getting it?
Yeah, the new one.
Clinic? Well, let's just say I don't have full authority to purchase it. I'm in an institution now, not a mental institution, an institution, a university setting, and there are many layers involved in purchasing new equipment. And this is because we have the Perfecta and we know how to use it very well. That's not first on our list, but I can't wait to get my hands on it. I've asked Perry Tomasetti, who's one of the engineers at Candela. He's asked me personally what things I would like to see in a laser, and I said I'm available to test it. So I'm hoping to actually get out to Boston to play with the device when it's out and available. And if I think it's going to be as good as I hope it is, I'm going to push pretty hard to get it. So that's a long-winded way of saying we don't have immediate plans. I'm hopeful that there may be room to purchase this device in the not too distant future.
And I want to, before we close, remind you all that we do post the free laser clinics on our website at birthmark.org and also on our Facebook page here. We have the one coming up in Italy, although it is completely sold out. We do have a wait list, and then we have one that will be in Miami in February at the Children's Skin Center at Nicholas Children's Hospital. And we'll be adding other ones next year as well. So always check back for those free laser clinics. Dr. Goldberg, thank you very much. It has been wonderful, very informational. There's just tons of people saying, thank you, thank you, thank you, thank you. There's like 9 different patients on here saying thank you to you for the very informative information. Some of our board members are on saying they learned a lot today. So thank you for your time, and hopefully we'll see you back again for another Facebook Live. Stay safe, happy holidays, and just stay healthy and safe. Thank you very much.
Thank you, everybody. Thank you, Linda, for putting this all together. Appreciate it.